Glucose is found in almost every food we eat, like bread, potatoes, or fruit. Once it's absorbed by the body, it's converted into a source of energy. The body needs the plasma glucose levels to remain within a pretty narrow range, between 70 and 110 milligrams per deciliter when you've had nothing to eat, and less than 140 milligrams per deciliter after a meal. Now, the entire blood volume is about 5 liters, and the plasma volume is about 3 liters of that. The kidneys filter the entire plasma volume 60 times a day, which means that our kidneys filter approximately 180 liters of plasma each day. If each liter of plasma has about 1 gram of glucose, this means that about 180 grams of glucose get filtered by the kidneys every single day. And that's known as the filtration rate of glucose. Also though, if you increase your blood glucose concentration, say to 1.5 grams of glucose per liter, then you'd end up with a filtration rate of glucose of 270 grams per day. Essentially, the higher the plasma glucose concentration, the more glucose will get filtered. Now, if we wanted to illustrate that in a graph, with plasma glucose concentration on the x-axis and the glucose filtration rate on the y-axis, then we'd see that as the plasma glucose concentration increases, the filtered load of glucose increases linearly. Now, looking at the kidney, specifically inside the kidney, there are two main parts, the outer cortex and the inner medulla. If we zoom in, there are millions of tiny functional units called nephrons, which go from the outer cortex down into the medulla, and back out into the cortex again. Each nephron has a glomerulus, which is a tiny clump of capillaries, where blood filtration starts. When glucose enters the glomerulus, some of it gets filtered into the renal tubule. Zooming in on one of these renal tubules, each one is lined by brush border cells which have two surfaces. One is the apical surface, which faces the tubular lumen and is lined with microvilli, which are tiny little projections that increase the cell's surface area to help with solute reabsorption. The other is the basolateral surface, which faces the peritubular capillaries, which run alongside the nephron. Now, the body needs glucose, and doesn't want glucose getting lost in the urine, so it tries to reclaim this filtered glucose right away, in the first segment of the renal tubule, known as the proximal convoluted tubule. Now, more than 99% of the filtered load of glucose is reabsorbed back into the circulation. But that doesn't just happen. There are obviously a couple steps to take to accomplish this. First, the glucose needs to cross the apical surface of the renal tubule cells. But normally the glucose concentration inside the cells is a lot higher than that inside the tubule. So in order for glucose to cross the apical surface, it requires energy. Fortunately, the electrochemical gradient of sodium drives it to move inside the cell. And that sodium gradient is sufficient to pull glucose into the tubule cell as well. More specifically, there's a sodium glucose linked transporter, or SGLT, that moves glucose against its concentration gradient, which is a process called secondary active transport. SGLT binds 2 sodium ions and 1 glucose molecule from the tubular fluid and releases them inside the cell. The intracellular concentration of glucose is high, so it quickly moves across the basolateral membrane through the process of diffusion, and makes its way into the peritubular capillaries, but only with the help of specialized glucose transporters, called GLUT1 or GLUT2. This process is known as facilitated diffusion. Now, we can summarize this process of glucose reabsorption using the same graph as before, but with plasma glucose concentration on the x-axis and glucose reabsorption rate on the y-axis. Initially, all of the filtered glucose gets reabsorbed back into the bloodstream, so the curve matches the filtration rate line. But there's only a limited number of glucose transporter proteins available, which means that if they're all busy moving glucose, additional glucose molecules won't speed things up anymore. And that starts to happen at a glucose plasma concentration of approximately 200 milligrams per deciliter. And once the glucose concentration is even higher, around 350 milligrams per deciliter, all of the carrier proteins are fully saturated. That difference between 200 and 350 milligrams per deciliter is because of the variation in the functioning of individual nephrons. But beyond 350 milligrams per deciliter, all of the carrier protein and virtually all of the nephrons are occupied by glucose molecules. So there are no more available to reabsorb the rest of the filtered glucose. This makes the reabsorption curve level out at its maximal point, which is known as the TM, or transport maximum. It also means that the excess glucose, which is the filtered glucose minus the reabsorbed glucose, gets excreted in the urine. The point at which this starts happening is called threshold. We can also draw out a final curve called the excretion rate of glucose on the y-axis. And this is literally just the difference between the two curves. And the initial curved part of the line, as it's going from no excretion to linear excretion, is sometimes referred to as the splay. Now, glycosyria, or glucose in the urine, is never something that's normal. And it often happens in uncontrolled diabetes mellitus, where the lack of insulin results in whopping levels of plasma glucose, well above threshold of 200 milligrams per deciliter. But keep in mind that a more mild abnormality in glucose concentration, like 150 milligrams per deciliter, might not cause glycosyria, because the threshold hasn't been met yet. On the flip side, sometimes the plasma glucose concentration is totally normal, but glycosyria still happens. One example of this is hormonal changes during pregnancy, which lead to increased blood flow to the kidneys. The increased blood flow means that more glucose gets filtered than usual, and that might be enough to go above the reabsorption threshold. Alright, as a quick recap. Normally, below a blood glucose concentration of 200 milligrams per deciliter, all of the filtered glucose is reabsorbed back into the bloodstream. And by the same token, none of the glucose gets excreted. Between 200 and 350 milligrams per deciliter, glucose transport proteins start hitting their saturation point. So some of the filtered glucose appears in the urine for the first time, and this is known as threshold. And the gradual increase is referred to as the splay. Above 350 milligrams per deciliter, all of the carrier proteins are fully saturated, and this is known as the transport maximum. So the excretion rate of glucose rises linearly with the filtration rate.
Helping current and future clinicians focus, learn, retain, and thrive. Learn more